All right, let's dive in. I want you to picture this. You're in the final, high-pressure oral exam for your surgical boards. The topic? A major liver resection. You are the candidate, I am the examiner. Everything you've learned, all your judgment, it's all on the line right now. The clock is ticking, and a patient's life is in your hands. Let's begin.
So, candidate, let's get right to it. You've got a patient in front of you with a large tumor smack in the middle of the right lobe of their liver. Surgery is on the table, it's their best shot at a cure. But before you even dream of picking up a scalpel, you have to convince me that you are truly prepared.
So, talk me through it. Where do you start? What are the absolute, non-negotiable, critical steps you take before this patient even sees the inside of an operating room?
Examiner, my assessment is completely systematic. First things first, I'm diving into the lab data. The liver function tests, or LFTs, tell me what I'm working with. How healthy is this liver at baseline? And of course, the coagulation profile is critical. This is a procedure with a high risk of bleeding. Next, I'm all over the imaging. A triphasic CT scan is basically my roadmap. It shows me the tumor's size, its location, its relationship to everything else. Then you gotta check the engine, the heart and lungs, to make absolutely sure the patient can handle a long anesthetic. And finally, I'm screening for portal hypertension. Why? Because if the pressure in the liver's plumbing is already sky high, the risk of catastrophic bleeding goes through the roof. You know, when it comes down to it, my whole evaluation boils down to two huge questions. First, I'm looking at the tumor itself. Can we actually resect this thing, or has it already invaded critical blood vessels or other structures? That's question one. Question two is just as important, though. It's about what we call the future liver remnant. After I take out that massive piece of liver with the tumor, is what's left behind going to be big enough and healthy enough to actually do the job and sustain life? Because if the answer to that is no, well, the operation can be a technical masterpiece, but the patient won't survive. Very good. So you've assessed the patient, you've assessed the tumor. Now prove to me you know the territory. I want you to describe the internal roadmap of the liver that is going to guide every single move you make. Of course. So the liver's roadmap, it all starts with its supply lines. You've got the hepatic artery, which brings in all the fresh, oxygen-rich blood, and running right beside it, like a parallel highway, you've got the biliary ducts, and their job is to drain bile out of the liver. Understanding this dual system, this inflow and outflow, is really the first step to making sure you don't cause a disaster during the dissection. And then you have the venous system. Think of the portal vein as this massive superhighway bringing all the blood from the intestines to the liver full of nutrients that need to be processed. At the same time, you've got the three huge hepatic veins collecting all that blood after it's been processed and returning it to the main circulation through the inferior vena cava. Let me tell you, controlling these massive vessels, that is the absolute key to managing blood loss in this operation. And when you put it all together, you get this beautiful, functional map. See, the liver isn't just a simple left and right lobe. It's actually divided into 8 independent segments. Each one has its own artery, its own vein, and its own bile duct. This segmental anatomy, this is our GPS. It's what allows us to do these incredibly precise resections, following these natural dividing lines. Excellent. So now you have the map. How does that map tell you which road to take? For a large tumor on the right side, what are your primary surgical options? Explain the difference. For a large right-sided tumor, the standard of care, our go-to procedure, is a right hepatectomy. That means we're removing segments 5 through 8, the entire anatomical right lobe. Now, if the tumor were on the other side, we'd be talking about a left hepatectomy, which takes out segments 2, 3, and 4. The tumor's precise address within these segments dictates the whole game plan. But the real key principle here, the philosophy behind it, is performing what we call an anatomical resection. We're not just going in and scooping out the tumor. No, we are removing entire functional segments right along their vascular planes. And the goal is singular, it is absolute. We have to achieve a clean, tumor-free margin of tissue. That's what gives the patient the best possible chance for a cure. The plan is sound. Now, take me into the operating room. It's go time. Walk me through the key phases of a standard right hepatectomy. Okay, so the operation itself has a rhythm, a flow. It unfolds in 5 critical phases. First up is exposure and mobilization. We have to free up the liver so we can get full access to everything. Step 2 is the hilary dissection. This is the delicate part, where we carefully identify and isolate the main vessels and ducts that are going to the right side of the liver. Third, vascular control. We very carefully tie off or ligate those structures.
Fourth is the parenchymal transection. This is the point of no return, where we actually divide the liver tissue itself. And finally, hemostasis and closure, making 100% sure there is no bleeding, no bile leaking before we even think about closing the patient.
Let me stop you right there, candidate. That's a high-yield point. During that hilar dissection for a right hepatectomy, why is it so absolutely critical to visualize the left hepatic artery? Because if you accidentally injure or tie off the artery going to the liver that's staying behind, that is a devastating, potentially fatal mistake. You have to see it to protect it.
Absolutely, examiner. Protecting that left-sided blood supply is paramount. Now, to actually perform that transection safely, we have some pretty amazing tools in our arsenal. We use things like the CUSA, which is an ultrasonic aspirator. It uses vibrations to gently break apart the soft liver cells, but it leaves the tougher blood vessels and bile ducts intact. That lets us see them and control them individually. It just allows for a much more precise and safer division of the liver.
You've completed the operation flawlessly, in theory, but surgery doesn't end in the OR. Let's rewind. How do you discuss this massive procedure and all of its dangers with your patient before any of this happens?
The informed consent conversation is a crucial three-part dialogue. First, I explain the procedure in plain language. Our plan is to remove the right half of your liver. Second, we discuss the alternatives. Are there other options like radiofrequency ablation or chemoembolization? And if so, why is resection still the best recommendation? And third, and this is maybe the most important part, I have to be completely transparent about all the potential complications.
And I mean really specific. I would detail the major risks of this operation, things like significant bleeding, a leak of bile from the raw surface of the liver, and the complication we all fear the most, post-operative liver failure, where the bit of liver left behind just isn't strong enough to do its job. And of course, there's always a risk of injuring the remaining bile ducts or other nearby organs. The patient has to understand every single one of these possibilities. Candidate, that is a comprehensive answer. And it leads us right to the final, and maybe the most difficult question of all. This isn't just about anatomy or technique. It's about judgment. In a procedure with so much on the line, how do we, as surgeons, balance that immense potential for cure against the very real and profound potential for harm? That right there, that is the gauntlet every single surgeon has to run.